purulent discharge or conjunctivitis in infected cases. Signs is sticky, mucopurulent discharge, and persistent epiphora are two important signs. So mainly tearing and sometimes with discharge. إذا كان عندي conjunctivitis. There is a regurgitation of mucopurulent pressure over the sac. So if you press over the lacrimal sac and the nose, you can find a mucopurulent discharge will come out through the lacrimal punctum. Discharging. This is how it looks. Both eyes have nasolacrimal duct obstruction, but here he has discharge as well. This is very important photo and very important slide. This is the investigation for nasolacrimal duct obstruction. The investigation is by dye disappearance test, DDT, dye disappearance test. You will just apply fluorescein drop, which is the orange drop, in both eyes, then to check on both eye clearance after 5 minutes. So you will just put fluorescein in both eyes, then you will check the fluorescein after 5 minutes. If the fluorescein stays or still pooling in the eye, this means that this eye has lacrimal system obstruction, and the most common structure in pediatric group to be obstructed is the nasolacrimal duct because of valve of hazard. So this is the dye disappearance test. You just put fluorescein drop here, fluorescein drop here. We can see that the fluorescein is here, but it drained already. Drained. يعني الفلوريسين just drained. But here عندي obstruction, فالفلوريسين stayed or pulled in the eye. So this eye is okay, but this eye has obstruction. As we mentioned. So obstruction mainly will be here in pediatric group. Treatment of nasolacrimal duct obstruction. Conservative treatment is indicated in early cases. You will just massage over the lacrimal sac area and clean the discharge several times a day. Method: teach the mother to apply pressure over the sac area by the thumb. By the way, it is very common. You may see this very common in your life. Then bring the thumb downward, pressing toward the ala of the nose. This is repeated 3-4 times a day. 3-4 times thrice daily. So you'll do it 3-4 times each time for 3 times daily. Massage increases the hydrostatic pressure in the sac and helps to open up the membranous occlusion. The membranous occlusion, which is what? اللي هو الvalve phasm. It's successful in around 90% of cases in the first year. No need for surgery. So, in the first year of life, most of the infants will not need surgery. Only massaging will do. Only massage will do. Then you can just give eye drops, antibiotic eye drops, if there is discharge. So most cases, 90% are cured by this treatment. They mean what? The conservative. They mean here the conservative, not the antibiotic. Be careful. Most cases are cured by this treatment. This is meant by the conservative, all of the conservative, not the antibiotic. Because the main treatment here is the massage. Main treatment, massage. The main conservative treatment is massage. We just give antibiotic if there is discharge. The second one is the surgical treatment, which is aimed to recanalize the nasolacrimal duct. This is the way of the massage. Treatment of congenital dacryocystitis, systemic antibiotics. This is how it looks. The dacryocystitis, inflammation of the lacrimal sac in children. You just treat it, then the child most likely will need surgery to recanalize the duct. Acute dacryocystitis in adults. It's acute suppurative inflammation of the lacrimal sac. Etiology, it usually occurs as an acute exacerbation of the chronic dacryocystitis. Starts spontaneously. It is caused by pathogenic pathogens such as pneumococcus, staphylococcus, streptococcus. Symptoms: there is marked swelling, redness, and tenderness of the skin over the sac and adjacent area. No regurgitation is present as the canaliculi are blocked due to edema. The symptoms very important to differentiate between acute and chronic dacryocystitis. Conjunctival congestion and submaxillary lymph node enlargement may be present. Fluctuation is present on palpation over the sac area when there is abscess formation. Lacrimal fossa, lacrimal fistula may be present in the abscess if the abscess bursts open repeatedly. Complications: osteomyelitis of the lacrimal bone, orbital cellulitis. This may be complicated to orbital cellulitis. Then cavernous sinus thrombosis, which is very serious condition. Treatment: hot compresses, systemic antibiotics, very important to give systemic antibiotics here. Analgesics and anti-inflammatory are effective. In case of lacrimal abscess, a vertical incision is given over the sac area and the lower part to facilitate the drainage by gravity. In case of lacrimal fistula, excision of the fistulous tract and removal of the sac is done. This is how it looks. This is acute. This is acute. Very obvious. It's acute. How can we know this? We have redness. We have swelling all over. We have fluctuation of the fluctuation. When you press, you can feel there is fluid inside. So this is acute dacryocystitis. Again, here we can have this is looks very obvious that it's acute. We have redness, we have swelling, this is fluctuation. And when you press this, when you press here, when you do like this on the area, you can feel there is something inside, fluid. This is the fistula. This is the fistula. Sometimes it opens. It just opens here. هذه الفستولة. الدوت هذه فستولة فتحة يعني. This is fistula. Now we'll talk about the chronic dacryocystitis, not the acute, the chronic dacryocystitis. Common chronic suppurative inflammation of the lacrimal sac that usually results from obstruction of the nasolacrimal duct. Its clinical importance as hypopyon or even panophthalmitis may occur after intraocular surgery. So dacryocystitis is caused, chronic dacryocystitis is caused by mainly nasolacrimal duct obstruction, will lead to dacryocystitis because of the tear stagnation. The tear will just stay there, and it will be good media for bacterial infection because the tear is زي المستنقع يعني بتصير. Because the tear will stay in the sac and it will not be moved, and it will be good media for infection. So it is usually due to stricture of the nasal duct as a result of chronic inflammation of the nasal mucosa, pressure of the nasal polypi, hypertrophied inferior turbinate, extreme deviation of the nasal septum. The stagnant sac gets infected by pugilic bacteria such as pneumococcus strep by a fungal called rhino. So common causes of epiphora: congenital absence of lacrimal puncta, congenital non-canalization or delayed canalization of nasolacrimal duct, occlusion of puncta, chronic dacryocystitis, growth or inflammation of inferior meatus, functional insufficiency for draining the tear into the nose. So the symptoms of chronic dacryocystitis: there is constant epiphora or passive overflow of tears over the lid margin, which is aggravated by exposure to wind. There is swelling pain and redness at the site of the sac mucocele in cases of acute or recurrent infection. Signs: persistent congestion of the neighboring conjunctiva, caruncle, and skin may be seen. Regurgitation of mucopurulent fluid overpressure is present. This is very important. Why? Number 2 is very important because number 2 is not present in the acute. In acute, there is no regurgitation. Why? لأن in acute we have that will close the puncta, because with the acute inflammation يكون عندي edema, يكون عندي swelling, the canaliculi and the puncti will be closed by the edema. But here there is no much of inflammation because it's chronic. يعني no redness, no swelling, no inflammation. يعني as you see, there will be nothing. So regurgitation can be done. What's regurgitation? Regurgitation, for example, this is a system. هذا lacrimal system. Regurgitation, if you press here يعني على area of the lacrimal sac, you can see fluid coming out from the punctum. العكس تصير، بدل ما هي تمشي كذا because you're putting pressure here, you will just push it out and you will see regurg from the puncti. هذا الليد هنا. This is the lid, for example. So you will see fluid coming out from the puncta. We can see this in chronic, but not in acute. This is the chronic. This is the chronic dacryocystitis, as there is nothing. There's very mild swelling here, but not the swelling as the lacrimal acute dacryocystitis. So you cannot find something significant here. No significant redness, no significant swelling. There is regurg. So regurg, if you press here, you can check هنا البنكتاي واحدة هنا واحدة هنا. You can check it with the slit lab. You can find a regurg fluid will come out because it's patent here. But with the acute, with the swelling here, the puncti will be closed. So chronic dacryocystitis investigations, nasal examination is important to exclude deviation of septum, growth at atrophic rhinitis, to judge this PCR operation. So then we have the lacrimal irrigation. Lacrimal irrigation, which is syringing of the nasolacrimal duct. You just put a cannula on the puncta and you irrigate it with saline, and you check if it's patent or not. Treatment, it's topical antibiotics if there is discharge and signs of conjunctival infection. So for chronic dacryocystitis, you can give topical antibiotics if there is conjunctivitis of the or there is discharge. If there is only tearing, no need. So antibiotics only if there is discharge, only if there is conjunctivitis secondary to the obstruction. The main treatment here is surgery by creating a new passage, which is DCR. DCR is dacryocysto-rhinostomy. So you will just create a new passage, DCR. Each letter is for some D So the name will give you the surgery. Dacryo, which is the lacrimal what? Sac. Dacryo, cysto, lacrimal sac. Then rhino, which is the nose. Ostomy, which is the new passage. So DCR, dacryo, cysto, lacrimal sac. Rhino is the nose. Ostomy, a new passage. So you will create a new passage. This is the surgery down here. A new passage between the nose or the nasal mucosa and the lacrimal sac. So instead of being drained like this, because there is obstruction here, you will just create a new opening in the middle of the lacrimal sac, and it will be drained here instead of here, because here we have obstruction. Is these are used in acute? No. In acute, you treat the acute infection first, then you will do DCR. In adults, not as in children, no massage in adults. The massage will not work. Massage will work only in pediatric, which is 90% will work. Decocystis, we have acute, we have chronic. You should differentiate between the acute and chronic. Acute, you should treat the acute inflammation first, acute infection with antibiotics. Then after the acute phase subsides, you will do the surgery. So the surgery for both. First year of life only, most likely yes. After the first year, success rate will be less. It's most likely it will be successful in the first year or year and a half. For example, مثلا 3 years, إذا كان 3 years, most likely يعني he will need surgery, which is most likely not DCR في الchildren, probing, تسليك يعني عملية تسليك فقط. We'll just do probe, يعني نحط سلك داخل البنكتا and we open the valve of Hasner. That's it for the lacrimal system. Any question regarding the lacrimal system before we go to an orbit? No questions?